Much. Not very easy to speak after Dr. Shah. First of all, of course, I want to thank the organizing committee for inviting me to this very interesting meeting. It's not my first visit in Turkey, but it's my first visit in this wonderful place. And thanks very much again. I'm from Marseille. Marseille, as you know, is a Mediterranean city on the border of the Mediterranean Sea. And this is the hospital where I work for now 30 years. But I prefer to show you where I live. This is the Old Harbor in Marseille. And my home is not very far from here, and sometime at 7 o'clock, when I have to go to the hospital in somewhere here, I would prefer to go by in a boat to fishing. Anyway, so my topic today is the impact of localization studies in the strategy for primary HPT. I think that most of you know what wrote John Dorfman, who was a famous radiologist in the state. And John Dorfman wrote this in '86. In my opinion, the only localizing study indicating a patient with untreated primary hyperparathyroidism is to localize an experienced parotid surgeon. So you don't need any localization studies at that time. And John Dorfman was absolutely right at that time. He was right for two reasons. The first one is that when an experienced parotid surgeon performs a parathyroidectomy with a bilateral exploration, the success rate is around 95 to 98%. And the second reason was that at that time, 30 years ago, none of localization studies approached the efficacy of an experienced endocrine surgeon in localizing an hyperfunctional gland. And this explains that for many years, the bilateral cervical exploration with identification of the foregland by the surgeon remained the gold standard in parotid surgery. But times are changing, and I think that this man was probably the first one to propose another exploration. That's a limited exploration, and Sten Tiblin, who was a surgeon in Lund in Sweden, proposed in '82 to perform a unilateral exploration in patients presenting a primary HPT. And as you know, today the concept of limited parotid surgery is based on the fact that 85%, at least 85%, at least in sporadic disease, present a single gland disease. And therefore, of course, if you know what there is a gland, there is no need to explore the other glands. This explains that today we have several possibilities to perform a parotidectomy. Of course, the conventional operation, that's the bilateral exploration. But we can also propose to our patients a minimally invasive procedure. A minimally invasive procedure that can be a unilateral exploration, a mini open operation, a radioguide by a mini incision, or some technique using the endoscope, the video-assisted technique, or the pure endoscopic technique. But I think that it's very important to keep in mind that firstly, parathyroid imaging is not a technique that should be used to make or to confirm the diagnosis of primary HPT. The diagnosis of primary HPT is achieved by metabolism test. This is very important. And the second point that you have to keep in mind, that if you ask for localization studies in a patient with an untreated, I insist, an untreated primary HPT, only non-invasive localization studies should be proposed. And in this case, the best is to combine a procedure that will give you anatomic and functional information, such as the 4-dimensional CT or ultrasonography combined with maybe CT scan. So, if today we want to assess the impact of localization studies on the strategy for primary HPT, there are three different circumstances. The first one is if you want to perform a conventional parathyroidectomy. Second case, if you propose to your patient a minimally invasive procedure. And thirdly, in case of reoperation for a persistent or a recurrent disease. Our localization studies indicate in case of conventional parathyroidectomy. This is the main question. And even if today localization studies are very accurate, it remains that an experienced parathyroid surgeon is still, in my opinion, the most sensitive, the most specific, and certainly the most cost-effective tool to identify an enlarged parathyroid gland. But nevertheless, localization study may reduce the operative time. This has been demonstrated by several studies. They may reduce the complication rate. They may reduce the failure rate. And maybe the most important, they detect major ectopic locations. About major ectopic location, we know that in most cases, ectopic location can be detected by an experienced parathyroid surgeon. And all parathyroid in the neck can be detected by an experienced surgeon, even when they are in a retropharyngeal area, as in this case, or when it's an undescended parathyroid adenoma, like in this case, that's shown by this MIBI scan. We know also that nearly all parathyroid adenoma located in the posterior mediastinum can be removed via the neck. This is an example of a parathyroid adenoma in the posterior mediastinum. This operation can be made by the neck. This is another example here. We know also that most of the parathyroid adenoma in lower ectopia in the anterior and superior mediastinum can be removed via the neck. This is another example of an adenoma at the level of the aortic arch, and this is another example. All these glands can be removed by an experienced surgeon via the neck. But in some cases, there is a failure rate, and the failure rate that accounts for 2 to 5% is related to ectopic glands deeply located in the mediastinum or in the anterior mediastinum or in the middle mediastinum. As you can see here, very low in the anterior mediastinum, or like another example, you can see the aorta, the descending aorta, and this is the adenoma, or in the middle mediastinum. These glands are, in my opinion, the only glands in ectopia that cannot be removed by the neck. And in this case, of course, localization studies are very helpful, because in this case, the cervicotomy should not be performed, and you can propose to your patient a thoracic approach that can be a lateral thoracic approach and eventually an endoscopic thoracic approach. But there is another reason to ask for localization studies in your patient. As you know, today, more than half of the surgeons performing parathyroid surgery perform minimally invasive technique when, of course, they are indicated. And if you want to propose to your patient a minimally invasive technique, there is a prerequisite condition. And of course, the prerequisite condition is that you should know where is the adenoma, that you need, before surgery, a clear localization of a single adenoma. So, let's explain that today, when you have a potential candidate for a minimally invasive procedure, and what is a potential candidate for a minimally invasive procedure is a patient presented a primary HPT, a sporadic primary HPT, without any suspicion of multiglandular disease, and without prior operation, and without large goiter associated. In this case, you can consider that this patient is a candidate for a minimally invasive procedure. And you will ask to this patient localization studies. That could be ultrasonography, that could be a CT, that could be a scintigraphy, depending on your institution and what you want to have. And therefore, there will be two possibilities. You have no, or you have an unclear localization. In this case, I don't think that you should propose to your patient a minimally invasive procedure. But if you have a very clear localization for one single adenoma, in this case, you can propose a minimally invasive procedure. So, this is the first impact of localization study in the strategy of primary HPT today, that localization study allows to choose the extent of the parathyroid exploration. You can either propose a bilateral exploration if you have no clear localization, or if you have a very clear localization for one single adenoma, you can propose to your patient a limited exploration depending on the technique you will use. But the operation will focus on one gland and you don't have to check other glands. Now, what are the impact of localization studies in patients for whom you propose a minimally invasive procedure? This suppose that we know exactly what is a minimally invasive parathyroidectomy. In my opinion, it's an operation requiring a small and discrete incision. But this is certainly not the most important. A small incision for a very direct access to one parathyroid gland, resulting in a focused dissection. And I think that minimally invasive means minimal dissection. Minimally invasive does not mean small incision. It's more important what you do under the skin than the skin incision, the length of the skin incision. So, to perform a focus, a limited dissection, you have to perform a very direct access. And I would say that the more direct the access, the less invasive the dissection. So, to perform a direct access, what we should know in parathyroid? The side in the neck, the right side or the left side, of course. If the level of the gland in the neck It's high level, low level. It's a superior gland or an inferior gland. And also, and very important, if the gland is in a superficial plane, if the gland is very anterior, or if the gland is deeply located in the neck or in the superior mediastinum. That's very important to decide which technique you will use. This is very useful because you will decide according to the location of the gland if the access you will use. And as you know, if you want to perform a minimally invasive procedure for parapet surgery, you can use two different access. The first access is the midline access between the stapes muscle. You perform through a small incision at the sternal notch, the division of the stapes muscle, and then you have to dissect the stapes muscle, and you can access to the parotid gland. But there is another access. This is the lateral access, or the backdoor access, and this access is performed by a small incision on the anterior border of the sternocleidomastoid muscle, and the plane that you have to dissect is the plane between the carotid sheath laterally and the stapes muscle medially, and you have a very direct access at the back of the thyroid. Therefore, if you know where is the gland, if you know where is the adenoma, if the adenoma is superficial or deeply located, you can decide the access. The midline access is certainly a very good access for a gland which is very superficial, and on the other way, the lateral access is certainly, in my opinion, the best access for a gland deeply located in the neck. Then, is it possible to know where is exactly the gland? Is the gland anterior or posteriorly located? Yes, it is possible, and it is possible thanks to the localization studies. You can use different procedures, ultrasonography, sestamibi, combine both localization, CT scan, etc. But in my department, we combine ultrasonography and sestamibi scan. I just want to show you by some example that you can exactly know where is the adenoma. Sometimes you get the answer immediately with ultrasonography. In this case, you can see this hypoechoic lesion at the back of the middle third of the thyroid lobe. This is a typical superior parotid adenoma, deeply located at the back of the thyroid lobe. This is another example of a parotid adenoma just at the tip of the lower pole of the thyroid lobe. In this case, you know that this is an inferior parotid adenoma, anteriorly, superficially located. This is another example of an inferior parotid adenoma. Here, you can see here the lower pole of the thyroid lobe. This is the thyrotomic tract, and here is the tip of the thymus. This is a very classical location of an inferior parotid adenoma, anteriorly located, superficially located. So, in this case, you can get the answer immediately with ultrasonography. You can also get immediately the answer when, with the sestamibi, you have such image. You can see the uptake at the middle third of the thyroid lobe. You don't need any localization study. You can be sure that in this case, this is a superior gland posteriorly located. But sometimes you need a complement of information. For example, in this case, you see the uptake of the parotid adenoma at the lower pole, at the level of the lower pole of the right thyroid lobe. You know the level of the gland, but what you don't know, if the gland is anterior or if the gland is posterior. If you hide for a profile, you can see that obviously the gland is posterior to the inferior pole of the thyroid lobe. Another example, you can see here the adenoma. This is the thyroid here. You know the level, the adenoma is below the inferior pole of the thyroid lobe, but what you don't know, if the gland is superficial, that is an inferior parotid adenoma, or if the gland is posterior. With ultrasonography combined, you see here the gland, and obviously the gland is anterior. This is an inferior parotid adenoma. But sometimes, as you know, some superior parotid adenoma can progressively degrade in a downward direction to the posterior mediastinum. And in this case, you can have, with the SESTA maybe the planar image, the same location. But if you perform a profile, you can see here that the adenoma is posteriorly located. So, by this example, I just want to show you that it's not very difficult to know exactly where is the adenoma. The level of the adenoma is a superior gland or an inferior, and if the gland is anterior or if the gland is posterior. And therefore, if you know where is the gland, if the gland is anterior, superficial or posterior, you can decide the axis you will use. If the gland is superficial, I think the midline axis is the best axis. But if the gland is posteriorly located at the back of the thyroid lobe or in the posterior mediastinum, in this case, I would consider that the lateral axis or the backdoor axis at the back of the structus is probably more adequate. But localization study can also have another impact if you perform a minimally invasive procedure. But with localization study, you can also choose the procedure that we will use. And as you know, there are different MIP procedures. And the question is always the same when we discuss about oversurgeon, about the interest of using a mini-open or endoscopic or video-assisted technique, is what is the main advantage of the endoscope? So this is the question. If you want to perform a minimally invasive procedure, what's the best procedure, a mini-open or an endoscopic procedure? The question is, why use the endoscope? If you perform a mini-open procedure, this is what you see, or at least this is what I see. I would say quite almost nothing, because if you perform a very small incision, and very small incision is no more than 1.5 centimeters, the view is not very good, even if you use headlamps and loops. And I would say that the shorter the skin incision, the more difficult is the dissection. And in my institution, we consider that a small incision, a true minimally invasive procedure, is an incision of less than 1.5 millimeters. What means less than 1.5 millimeter? It means that I cannot introduce my finger. If you can introduce your finger, it's more than 1.5. It is our criteria in Marseille. Less than 1.5 means that you cannot introduce your finger in the wound. So, if you don't see very well by such incision, if you introduce an endoscope, this is what you see immediately. You see much more. You see much more because you have, of course, the magnification of the camera, but in my opinion, more important, you see much more because you have the light. So, I would say that the main interest of using an endoscope in minimally invasive technique is not that you can perform a parotiodectomy for a small incision. The main interest is that you can perform a safe parotiodectomy for a small incision, a safe parotiodectomy. As safe as in open is conventional parotid surgery. So, the next question is, when should we use the endoscope? Is the endoscope necessary in all minimally invasive procedure or not? And once again, localization studies will give us the answer. Use the endoscope when there is a risk. What is the risk in this case, in this operation? The risk, of course, is the nerve. So the next question is, when is the risk? The answer is very clear. The risk is when the adenoma is close to the nerve, that is, when the adenoma is deeply located. This led us to propose 3 different locations for parotid adenoma. The first one, location 1, is when the adenoma is posterior to the 2 superior thirds of the thyroid lobe. The second location is when the adenoma is at the level or below the inferior pole of the thyroid lobe, but in a plane posterior to it. And the third location is when the adenoma is at the level or below the tip of the inferior pole, but in the superficial plane. This is location 1. The adenoma is at the back of the thyroid of the middle and the superior third pole of the thyroid lobe. This is the location of superior parotid adenoma. This is location 2. The adenoma can be at the level or below the inferior pole of the thyroid lobe, but in a plane posterior. And this is location 3. The adenoma is at the tip or below the inferior pole of the thyroid lobe, but in a plane superficial anterior. Therefore, if the nerve is at risk, use the endoscope. In location 1 and in location 2, where is the nerve? The nerve is here. The nerve is certainly at risk. In this case, of course, use the endoscope. But in location 3, when the adenoma is very superficial, the nerve runs much more deeply, and there is no risk for the nerve. In this case, you don't need to check the nerve during the procedure, and in this case, you don't need the endoscope, and you can perform safely a mini-open procedure without any endoscopic equipment. So, this is the third interest of localization study, that you can also decide the technique you will use if you want to perform a minimally invasive procedure. And to summarize, the first interest is to decide the extent of the exploration. No or unclear localization, I think that the patient should be operated by a standard cervicotomy with bilateral exploration. If you get a clear positive localization, you can propose to your patient, if the patient, of course, is a good candidate for this operation, you can propose a minimally invasive procedure. And then, according to the location of the adenoma, you will propose an anterior access if the adenoma is anteriorly or superficially located, or a posterior or lateral access or backdoor approach if the adenoma is posterior. And thirdly, you can decide the procedure if the adenoma is anterior. You don't need the endoscope, you can perform a mini-open procedure. If the adenoma is posterior, the endoscope is very useful to get a better view. And just to show you, in our experience in Marseille, what was the impact of localization study during the last 10 years. We performed nearly 2,000 cases of primary HPT, and you can see that in 46% of cases, the patients were operated by conventional parotid surgery, and in 54% we proposed a minimally invasive procedure. And it was possible to propose in this patient in more than 1,000 cases, it was possible to propose a minimally invasive procedure because we get before surgery a good localization. And among this procedure, you can see that when the gland was posteriorly located, that's in location 1 and 2, we propose an endoscopic approach. And when the gland was anteriorly located, superficial, the endoscope was not necessary, and we used the mini-open approach. Now, I want to finish this talk by a few words about the impact of localization studies in case of reoperation for persistent or recurrent primary HPT. It was demonstrated that when the first operation is performed by an inexperienced surgeon, a reoperation performed by an expert is successful in 95% of cases. And we also should keep in mind this. But nevertheless, today, I think that everybody agrees that preoperative imaging is certainly valuable for any patient who present a persistent or a recurrent disease. That means that in all cases of persistent or recurrent disease, localization studies are needed. They are very useful for the same reason that in patients with untreated parotid, because they may detect vasoectopic location, because they may reduce operative time, because they may reduce the complication rate, and of course because they may reduce the failure rate. And in this case, you have to ask for all the localization study until you get the clear location. That means that you can ask for, of course, non-invasive study, but also for invasive study. And keep in mind that what you need a localization with anatomic information and functional information. This explains that in today, because localization studies are very accurate, if you combine non-invasive imaging study, the sensitivity is up to 88%. And when you combine invasive procedure and non-invasive procedure, the sensitivity is nearly 95%. That means that today, nearly in all cases, you can localize the ectopic gland if the gland is ectopic. So, to my opinion, the only question today in this case is whether reoperative surgery is indicated when localization studies are negative. This is certainly very difficult to answer your question. You have a patient with a recurrent disease. You perform all the localization study, invasive, non-invasive, you combine, and you still don't know where is the adenoma, where is the gland, the suspicious gland. Very difficult to give the answer where, and that is certainly very questionable. In my opinion, I think that if you have suspicion of a solitary adenoma, that means it's a patient with obviously a sporadic disease, and during the previous operation, no gland was identified, or at least the glands which were identified were strictly normal. But probably the patient presents an adenoma that you don't know where is it. In this case, is the operation indicated once again? I think no, because you have no reason to think that the gland is more in the neck than in the chest. and I think in this case you have to wait to ask for new investigation 6 months or 1 year later. But if you suspect or if you have the evidence that the patient presents a multiglandular disease, that means that during the previous operation one or several glands were enlarged and obviously pathologic. In this case, very often localization study show nothing. And in this thing, I think that you have to consider that you, the surgeon, you are probably the best tool to find the gland, and in this case, I think that you can propose to a patient a reoperation. So, and this is my last slide. I would say that 30 years ago, localization studies had no impact on the strategy of parotid surgery. But today, the parotid surgeons depend highly on the quality of preoperative imaging studies to make a judicious choice for the appropriate indication for an application of the currently available surgical techniques. Thank you very much.
Teşekkürler Doktor Jean-François.